The broadcast is now starting. All attendees are in listen-only mode.
Hi everyone, this is Bethany O'Connor and we are just about to get started. We'll start promptly at 9 o'clock Eastern. Thank you so much for joining us. Hello everyone, and thank you so much for joining us. This is Bethany O'Connor from Health Policy Plus, and I am delighted to welcome you to today's presentation titled Creating a Supportive Policy Environment, Identifying Barriers and Enablers to Integrating FP into UHC Schemes. We have a great broadcast for you today, and we'll begin with just a few announcements. First, this broadcast is being recorded, and we'll make the recording and slide deck available on the HP Plus website. Next, we would love to hear from you, and we welcome your questions at any time. Please submit your questions via the chat box on the right-hand side of your screen, and I will read them aloud when we pause for questions. Also, these web conferencing platforms are getting an unusually high amount of traffic these days with COVID, so we just ask that you bear with us in case there are any little glitches with the technology. We'll get it back up and running as soon as we can. Just hang with us. Finally, we ask that if you're not speaking, that you please mute yourself to keep the line nice and quiet while others are talking. And that concludes the little announcements portion. So let's meet our presenters. Next slide, please. Our presenters today are Elise Lang and Aaron DeGraw from Health Policy Plus, joined by Dr. Norohaingo Adrianaivo from HP Plus Madagascar and Dr. Carlo Panello from the USAID ProtectHealth project in the Philippines. Now that we have met our wonderful panelists, I will now turn it over to my colleague Elise Lang to start our webinar today. Elise?
Thank you, Bethany, for the introductions. I would like to first get us started with the agenda for today's session. As Bethany mentioned, we'll hear from 4 presenters, starting with myself, Elise Lang, and then Aaron DeGraw from HP Plus, where we will introduce a new framework and corresponding checklists aimed at supporting policymakers to identify barriers and enablers to family planning inclusion in universal health coverage, or UHC. Afterwards, we will hear from Dr. Norohaingo Adrianaivo from HP Plus Madagascar and Dr. Carlo Panello from USAID ProtectHealth project in the Philippines on the case studies that were developed in Madagascar and the Philippines using this framework. We will conclude with a short summary, and then we will open it up for a question and answer session. Next slide. So why is this framework needed? On average, countries in sub-Saharan Africa have the lowest contraceptive prevalence rate at 32% and highest unmet need for family planning at 23%, suggesting significant investments are needed to improve access to and utilization of family planning. Many of these countries have been proactive in scaling up family planning by signing FP 2020 commitments and setting related targets under the Sustainable Development Goals. However, many family planning programs are underfunded compared to the resource needs outlined in their costed implementation plans, and domestic sources are not able to fully meet the needs, as you can see in the table. According to FP 2020, 45% of family planning funding in the 69 priority countries comes from development partners. Yet total external funding for family planning has steadily declined since 2014. To ensure sustainability, family planning needs to be considered in national and global actions to achieve UHC, including health sector reform that increases access to quality, essential services, and reduces out-of-pocket spending. However, family planning is not always considered in the design, introduction, or scale-up of health financing mechanisms such as social or national health insurance. Changes to laws, regulations, and policies, or as we refer to them as policy instances, that often accompany the introduction of new health financing mechanisms aimed at achieving UHC are not always attuned to the specific aspects of sustainable, high-quality family planning programming. These insights can limit the ability of family planning programs to contribute to and benefit from the achievement of the SDGs and reforms aimed at achieving UHC. So in response to this, we developed a framework that examines the integration of family planning in the legal, regulatory, and policy aspects of health financing arrangements aimed at achieving universal, affordable access to essential health services. It acts as a diagnostic tool to identify critical barriers and enablers in creating a supportive environment for family planning financing. The intention is that the framework will support country-level decision makers pursuing health sector reform and/or scale-up of health financing schemes to achieve UHC or the SDG Goal 3, such that these changes also benefit universal access to high-quality family planning services. Next slide. This graphic represents a summary of the framework. You can find a copy of the full framework in the guide posted on HP Plus's website. The framework is based on the intersection of the outcomes articulated in USAID's vision for health system strengthening and the roles of health financing actors. The intersection of these two concepts can be viewed as a matrix, with health system strengthening outcomes as rows and health financing actors as columns. Each cell in this matrix corresponds to a specific outcome in achieving universal health coverage, the rows, and to a specific actor, the columns. Each cell then describes aspects of country-level laws, regulations, and policies that can be enabling or inhibiting. The framework therefore helps a user identify policy instances that benefit or impede family planning. The health systems strengthening outcomes, or the rows, are population coverage of family planning services, the responsiveness of family planning services provided, which includes the range of methods and services included in the package of services covered by health financing systems or health insurance schemes, and the financial protection offered in the delivery of these services. For example, protection from out-of-pocket payments required for a typical family planning user. The framework then examines those different outcome dimensions in light of who is affected, or the health financing actors, the columns. Payers are affected by policy instances that govern how family planning services are paid for and by whom. Often these will be government entities such as a social health insurance agency or a national ministry or a private insurer who covers a package of family planning services. Payers may draft the regulations which affect the next two set of actors. Providers are affected by policy instances that affect how and where family planning services must be delivered and what can be paid for them. These include facility-based or community-based providers, whether an individual health worker or group providing family planning services. Family planning users are affected by policy instances that govern whether and how an individual can demand and receive family planning services. Such services include information and counseling and the full scope and breadth of the methods. The framework was developed specifically to examine the legal, regulatory, and policy implications for financing high-quality family planning services. It's not intended to provide a generalized or broader review of the enabling environment for family planning as a whole. As it was developed as a tool that can be used across different country and legal contexts, the existence and content of each policy instance will differ from country to country. However, across all the contexts, The framework allows users to identify relevant policy instances and conduct a content review to identify the elements within the instance that support or inhibit the population level coverage and access, increased responsiveness and method choice, and financial protection in seeking family planning services. I'll now turn it over to my colleague, Erin DeGraw, to tell you more about how to use the framework.
Great, thank you, Elise. To help stakeholders actually implement the framework, we developed a corresponding checklist. The checklist is organized into a cascade of questions that breaks down the framework in a user-friendly format, which helps stakeholders capture information in a concise manner. The checklist itself is about 10 pages, so I'm not going to go through in depth each section, but we'll provide a high-level overview into how it's structured. If you look at the image, you can see the checklist has 3 columns. The specific policy instance related questions, the outcome actor column, which lists the health system strengthening outcome, the population coverage, responsiveness, or financial protection, as well as the health financing actor, payer, provider, or family planning user, that the question corresponds within the framework. And then the last column provides a space to add notes to capture more nuanced information for each of the questions. We recommend users provide written responses beyond the binary yes or no for each question to provide sufficient information for a detailed review and discussion. The checklist is set up in a funnel approach that gets more detailed with each question. It has 3 sections. In the image here, you can see the part of the first section, laws, ordinances, and Supreme Court rulings. You can see that it starts with questions around higher level laws and ordinances, beginning with whether a country has a law that grants the universal right to health with corresponding questions. These questions give stakeholders a broad understanding or starting point on whether citizens have the legal right to health, whether their government is legally mandated to help cover the cost of health care, and whether family planning is explicitly included in these rights. Then, as you move down the sections, the questions start to focus on more specific laws, such as the safe drug law, health insurance laws, which you can see here, and then further down it includes family planning and reproductive health laws, which have a number of corresponding questions, and then Supreme Court decisions and executive ordinances. The second section focuses on regulations, such as health insurance regulations. Here, the checklist includes questions on whether and how family planning is included as part of the health insurance benefits. Some of the other policy instances covered in that section are import regulations, the essential medicines list, and the specific health facility regulations. The third section includes questions on relevant policies such as the National Family Planning Policy, a Universal Health Coverage Policy, and Community Health Policy. These provide more granular level guidance on how family planning should be implemented. Finally, we do want to point out that each country's policy landscape is different. The checklist is meant to suggest starting points for the type of policy instances that could be included in a country case. However, some countries may require review beyond what is included in the checklist. So now that you have a brief introduction to both the framework and the checklist, we'll now discuss how they can actually be applied. The use of these tools requires an inclusive and engaged process. The figure here shows 6 steps to effectively apply the framework. As you can see, we recommend working with a diverse group of stakeholders as part of the analysis team, hosting an initial workshop to go through the checklist. The analysis team should start by using the checklist to identify policy instances that govern overarching rights to health and to identify other laws that affect the healthcare system as a whole and family planning more specifically. These may include laws and regulations governing the formation and implementation of a national or social health insurance scheme, government-supported non-insurance health financing schemes, or mechanisms of service provision. The number and type of policy instances available for review may vary by country, depending on the legal and regulatory system and maturity of the national level health financing arrangements. Once the team has identified relevant policy instances, they should delegate who comprehensively will review each of the documents. The intention of the review is to understand whether each individual element in a policy instance, the clauses or the articles, enable or hinder the intended outcome. For example, reviewing health insurance regulations may show that long-acting reversible contraceptives are included in the benefits package. However, the removal of implants and IUDs was not explicitly included in the benefits design. This absence of explicit language may invite an out-of-pocket cost for users seeking removal services. This gap would undermine overall government efforts to effectively provide affordable family planning services free of financial barriers to access. I'm giving this example because it's this type of nuanced information that is critical in the policy analysis. Barriers can exist in a number of forms. The absence of language, as shown in this example, language explicitly stating a barrier, such as if the family planning law explicitly states that adolescents need written consent from parents to access contraception, or even due to the complete absence of a policy instance. Reviewers should be identifying these details and capturing them in the notes section of the checklist for further discussion with the analysis team. And then finally, once the review is complete, the team should reconvene to discuss and validate findings. The insights generated can then be used to advocate for removal of barriers, to strengthen existing enablers, to protect enabling policy instances during reforms, and/or to address identified gaps within the policy instances. With this in mind, the team should develop an action plan to include these revisions into costed implementation plans, FP 2020 action plans, and health financing and universal health coverage related reforms. So, in order to test the application of the framework and checklist, we conducted 2 case studies, one in Madagascar and one in the Philippines. We selected these countries because they offer different health sector reform and health policy development levels and contexts across 2 different continents. The Philippines has an advanced legal and regulatory environment with more mature health financing arrangements, including a strong national health insurance system, which have direct applicability to financing family planning. In comparison, Madagascar has low health financing maturity and doesn't have an established national or social health insurance system, and has an absence of policy instances that govern financing family planning. The results of these case studies offer insights into 2 types of barriers that can be encountered in financing universal access to affordable, high-quality family planning across 2 very different contexts. So how do we actually do our case studies? Each case study analysis was developed in 3 stages. First, a desk-based review. Second, stakeholder consultation. And third, revision and validation. For the desk review, we used the checklist to organize and review the policy instances in each country. Most of the documents collected were widely available through online searches, including government websites and online newspaper sites, though some were obtained through key informants. Once we completed the initial desk review and analysis, we conducted initial stakeholder consultations. These consultations were conducted with support from the FP 2020 Secretariat and FP 2020 focal points in country. Consultation involved virtual meetings to discuss the enabling and barrier policy instances that were found in the initial desk-based review. Our goal was to be as inclusive as possible of a wide group of stakeholders from within the country. So the consultative meeting included government officials, usually from the Ministry of Health, USAID staff, staff from UNFPA, as well as multiple civil society and implementing representatives. We found the stakeholder consultation to be critical as it helped uncover informal rules and norms around how policy instances are interpreted or implemented in country. This helped us to further contextualize and define the identified enablers and barriers. Our final step was to revise our analysis based on the information gathered in consultative meetings and validate the final results. We are in process of finalizing these case studies reports and are hoping they'll be published and released in the next couple of months. With that, I'll turn it over to my colleague, Dr. Nurhang Adrianius, to share insights into the main policy enablers and inhibitors for sustainability financing family planning in Madagascar.
Thank you, Erin. Hello, everyone. My name is Dr. Nurhang Adrianius. I'm our HFP advisor with HP Plus Madagascar, and I'll be presenting on the framework application in Madagascar. Next slide, please. First, it's important to understand some background about Madagascar. From 2009 to 2013, Madagascar suffered a political and economic crisis that delayed the development of the healthcare system. However, the country has still made significant strides in family planning. As you can see, modern contraceptive prevalence rate among all and married women has increased significantly from 2013 to 2019 as projected by Track 20. In addition, the government is highly supportive of RMNCAH and family planning, having signed on to global commitments like FP 2020, as well as replacing an outdated reproductive health and family planning law with a new law and corresponding decree that provide a universal right to access reproductive health and family planning. These already sets the stage for a strong enabling environment for family planning. However, the health financing system is still weak. Financing schemes remain nascent, and domestic funding for health is low and unable to meet the needs of the population. While Madagascar has some mechanisms for offering financial protection, they are fragmented and cover a small percentage of the population. The absence of certain types of policy instances, such as those regulating health insurance schemes, creates more barriers to family planning financing compared to the policy instances that do exist. The next slide shows us the policy instance enablers. Here, you will see that we have broken down the laws, regulations, and policies that are enabling by the health system strengthening outcomes of the framework. To start, in terms of population coverage and access, the RHFP law I mentioned previously provides a great layer of protection by prohibiting all forms of discrimination. The law also requires the government to mobilize the necessary resources to enable the provision for family planning services and to support awareness raising, promotion, and publicity of family planning services. This allows for and promotes access to a broad population. While the 2020 RHFP decree explicitly allows community health workers to provide injectables, this wasn't always the case. Due to concerns about injectables being used inappropriately to fatten hogs, the Ministry of Public Health temporarily suspended it in 2018, and therefore the provision was not included in the policy documents finalized then, such as the community health policy. However, injectable is one of the most preferred methods in Malagasy women. Yet, in April 2019, the Ministry of Public Health signed a policy note confirming its revitalization, and the RHFP law's degree validated in January 2020 specifically protects community health workers, providing the service and increases access and choice. Lastly, there are a few financial protection policy instances that encourage access to affordable services. Family planning services have been provided for free at public facilities for over a decade, and the new RHFP law decree solidifies this by requiring contraceptives to be free at public facilities. Another recent policy win is the tax exemption of contraceptives in the 2020 government financial law. Previously, the customs import tax rules required a 20% import tax on contraceptives. Private importers of family planning commodities could have passed on the tax cost via retailers to the family planning user, who would have to make a choice to absorb this increase or discontinue use or choose not to seek services. However, with contraceptives now being tax exempt, it allows importers to sell contraceptives at a fairer price. Now, let's move on to the policy instance barriers. While the RHFP policies and laws suggest an enabling policy environment for family planning, the broad health financing related legal framework of Madagascar does not actually provide support for enhanced population level access and coverage, responsiveness of services, or financial protection. Because there is no UHC-related law or national or social health insurance scheme in Madagascar, and the private health sector is weakly regulated, there are no policy instances requiring family planning to be included in health insurance benefits. Due to the absence of an overarching policy instance, there is no specific legal support related to ensuring diverse method mix, adequate reimbursement to providers, or affordable or equitable access to family planning within prepayment schemes like insurance. While services and contraceptives are free in the public sector, with little regulation of the private sector, there aren't any rules, for example, that may restrict charging high or informal fees. Also, as I mentioned, the RHFP law provides a lot of protection. However, there is still limited access to emergency contraception, as it requires a prescription and cannot be provided by community health workers or pharmacists, as WHO recommends. That this limits a woman's access and choice. Overall, Madagascar has a strong enabling environment for family planning financing. However, barriers exist, and it will be important for us in Madagascar to consider the implications to family planning as the country undertakes future health financing reform aimed at UHC. For example, the development of the new health financing policy provides an opportunity to ensure family planning is included in the package of services provided to ensure broad access and long-term sustainable financing. Thank you for your attention, and now I will pass it over to my colleague Erin to tell us about the Philippines experience.
Great, thank you. So now digging into the Philippines. Oops. As you can see on the first graph, the modern contraceptive prevalence rate for married and all women has only increased by about 2% from 2013 to 2019. And while the country has mature health financing structures, including a wide coverage under the National Health Insurance Scheme, out-of-pocket expenditures on health remain high at 53.9% in 2018. As you'll see in the following slides, this context is reflective of challenges that still exist in financing for family planning. The Philippines has had a long journey toward achieving universal access to family planning services. The Responsible Parenthood and Reproductive Health Law, or Reproductive Health Law as it's normally used, was issued in 2012, which was a landmark legislation which aims to revitalize the family planning service provision, increase voluntary use, and reduce unmet need for family planning. However, the country's Supreme Court stopped the implementation after conservative groups filed for a challenge over its constitutionality. It wasn't until 2014 that Supreme Court ruled that the RH law is generally constitutional, except for 8 provisions that weren't applied. Then, in 2015, a temporary restraining order was issued to restrict the procurement and utilization of contraceptive implants. While the restraining order specifically focused on contraceptive implants, the Department of Health and Food and Drug Administration were prohibited from registering and recertifying all contraceptives until the restraining order was lifted in 2017. Due to these legal impediments and resulting programmatic issues, the reproductive health law was not fully implemented until 2017. Today, the country is in a transitional period of ongoing health system and financing reforms. In March 2019, President Duterte signed the UHC bill into law, which may significantly impact how family planning will be financed and implemented moving forward. As the UHC law's implementing rules and regulations were released this past October, full impact of the UHC law provisions still remain indistinct. I will therefore discuss some of the identified barriers and enablers to high-quality, affordable family planning services within the existing legal, regulatory, and policy environment before passing it over to my colleague, Dr. Carlo Pinello, to discuss some of the current implementation challenges. So, starting with the policy enablers, like the Madagascar case study, we've broken down the laws, regulations, and policies that are enabling by the health system and strengthening outcomes framework. Starting with population coverage, the RH law provides a foundation for reproductive health rights for all Filipinos, calling for universal access to medically safe, affordable, and quality reproductive health care without discrimination. The law mandates that the Department of Health, as the leading body to procure, distribute, and monitor family planning supplies for the full country, collaborating with the country's National Health Insurance Scheme under the Philippines Health Insurance Corporation, better known as PhilHealth, to ensure access to affordable services. PhilHealth benefits, which include long-acting and permanent methods, have widespread population coverage with membership of more than 92% of the population. The Department of Health also supplies short-acting methods for free in public facilities. This allows for and promotes access to a broad population. The Philippines policy environment as a whole promotes a diverse method mix in both the public and private sectors. With the lift of the temporary restraining order in 2017, the Food and Drug Administration recertified 51 contraceptive products, including subdermal implants, which have subsequently been included in the National Drug Formulary and Essential Medicines list. This allowed the DOH to attempt to distribute the large built-up inventory of commodities procured over 2016 and 2017. For financial protection, policy instances in the Philippines, in principle, provide a strong basis for reduced financial barriers to access modern contraception, especially for those from poor and vulnerable populations. The RH law requires free family planning services for poor and marginalized individuals identified under the National Household Targeting System, and any surgical services rendered under PhilHealth's bilateral tubal ligation and non-scalpel vasectomy packages are covered by a policy of no balance billing for poor and vulnerable members. This means a mandatory zero copayment and 100% of the bill covered by insurance in all government and certain contracted private health facilities. However, as we move into the next slide, you can see that the financial barriers some financial barriers still remain. So, in terms of barriers, starting with the population coverage, the Supreme Court's requirement of parental and spousal consent creates unnecessary administrative barriers that restrict some users' access to and demand for contraception. At the provider level, the RH law and corresponding implementing rules and regulations allow for conscience-driven opt-out of family planning provision, which creates a significant barrier to family planning access. While the RH law requires health providers to refer clients immediately, either within the same facility or one which is conveniently located, the Supreme Court nullified this provision except in cases of emergency. It follows that denial of services or referral would create unsatisfied demand and severely limit the potential user's access to and potentially continuing subsequent demand for family planning services. Under the Safe Drug Law, the FDA is required to assess and approve each batch of family planning commodities as safe and non-abortifacient. The assessment process is time-intensive, creating frequent delays in commodity distribution. As a result, facility-level stock shortages lead to lower provision of certain methods compared to demand, restricting access of family planning services and limiting method choice for family planning users. Further, due to the definition of abortifacient, government hospitals and local government facilities are prohibited from purchasing and requiring emergency contraceptive pills, which leaves many women unable to access a family planning method that can substantially reduce the risk of unintended pregnancy. As we move on to as we discussed in the previous slide, even with significant financial protection, barriers still exist. Currently, there is no policy instance that regulates copayment for family planning services not covered under the no balance billing policy across the public and private sectors. Private facilities can charge amounts exceeding PhilHealth reimbursement for those services, requiring out-of-pocket payment for additional costs. Additionally, certain required services are excluded in the benefits design altogether, such as the removal of implants, which then also invite an out-of-pocket cost expenditure by implant users. These gaps detract from the overall government efforts to effectively provide affordable family planning services free of financial barriers to access. With that, I'll turn it over to my colleague, Dr. Panelo, to talk about some of the key implications for family planning implementation.
Hello, everyone. I'd like to thank Health Policy Plus for inviting me to participate in this webinar. I'm going to give a context on why there seems to be very slow progress in the growth of contraceptive prevalence rate, as well as the relatively unchanged structure in terms of health financing in the country. And one particular context there that I would like to zero in this evening in relation to the implementation of the UHC law is the fact that since 1992, the public sector health system of the Philippines has been devolved with basic services being made a responsibility of local government units. All in all, in the country, there are close to 3,000 of these local government units, cities, and municipalities that are autonomous in terms of the way they would be providing services, family planning, among others. And the issue of fragmentation in the delivery and financing of services has been seen as the main driver behind the limited performance of the program, as well as the lack of financial risk protection when it comes to healthcare. And the passage of the Universal Healthcare Law in 2019 was seen as the answer on addressing this issue of fragmentation by consolidating local governments at the province-wide level. And with that comes the bigger question on how to redefine the roles and responsibilities of the national government and the local government in delivering family planning services. So at the national level at present, the family planning program is being co-managed between the Department of Health and the Commission on Population. Having two agencies running the family planning program is of course very enabling in the sense that family planning is getting support as well as attention from two separate government agencies that have their own budgets to actually complement each other's efforts. But having two management entities as well for a public health program can also mean higher transactions costs in terms of coordination. But the bigger challenge really, and as part of UHC implementation, is being able to delineate what family planning services will be the responsibility of national government vis-a-vis the local government. And the diagram at the bottom of the slide illustrates the kind of decision-making that needs to happen as part of implementing the UHC law. So family planning services here is treated as the illustrative case, but the same would apply to all the public health programs that are currently being handled by the Department of Health. And the first one would be to decide which of these services can be classified as population-based or individual-based. Population-based here is being defined as a service component that the benefit does not necessarily accrue to any single individual and is actually closer to the technical definition of what we would call as public goods. Once it's decided, population-based interventions will again have to be delineated in terms of being a devolved function, which means it will be assigned to the local government unit, or a non-devolved function, which means it will be retained as a function of the national agency, the Department of Health. On the other hand, delineation of the individual-based services will again have to be reclassified in terms of being a devolved versus a non-devolved function. And non-devolved functions will be primarily financed through PhilHealth, the Social Health Insurance Corporation of the Philippines. These are the questions that need to be answered as part of implementing the Universal Healthcare Law. And resolution of these questions actually will address several of the barriers that were mentioned in the earlier slide as part of the case study for the Philippines. Next slide. But the implementation of universal healthcare would now have to adapt to the new normal, as all of us are currently being confronted with, particularly how we adapt to the new normal of COVID-19. And in the immediate sense, the Philippine Department of Health is dealing with the immediate consequences of having service delivery interruptions due to the quarantine and due to the fact that many of the staff and other resources are being diverted to COVID-19 response, which is quite understandable in the context of an emergency. And universal health coverage interventions may be delayed or deferred. And while it is not yet official, we have heard already that the planned introduction of the primary care package in 2020 by PhilHealth will be deferred to 2021. But an even bigger challenge for the family planning program in the Philippines is to actually adapt to the new normal in the medium to long term. And this includes developing new service delivery standards and strategies that adapt to a situation where, as much as possible, limited human-to-human interaction is desired in order to prevent transmission of COVID-19. And the family planning program will need to look at opportunities to build on what COVID-19 service delivery infrastructure and mechanisms are going to be defined. So a common question being asked now is, how do you deliver family planning services, for example, in areas that are under quarantine? And many innovations are actually being employed by the different local governments, which is also, I think, the beauty of having a decentralized system. But from the financing lens, our primary concern, of course, is that universal health coverage funding is at risk from being diverted to COVID-19 control and will delay implementation of UHC as was originally planned for the Philippines. So I will end there, and I hope I was able to give some context on the recent challenges that the Philippine government is facing as far as family planning implementation is concerned. Over.
Great. Thank you so much, Dr. Penello. So I'm going to conclude our presentation with a short summary of what we've heard today. As I mentioned in the beginning of the presentation, external funding for family planning has steadily been declining. Therefore, it's critical for family planning to be considered in the national and global actions to achieve UHC so that it's not left behind. The framework and checklist discussed is therefore intended to support country-level decision makers pursuing health sector reform and our scale-up of health financing schemes to achieve UHC and SDG Goal 3, and act as a diagnostic tool to identify critical barriers and enablers in creating a supportive environment for family planning financing. Application of these tools requires an engaged and collaborative process. It's important to work with a diverse group of stakeholders and experts in country. We found this consultative step in our review process to be absolutely critical for identifying the informal rules and norms around how policy instances are interpreted or implemented in country. This information played a large role in how we contextualized and defined the identified enablers and barriers. The insights generated during the review should be used to then advocate for an improved policy environment. Stakeholders should develop a concrete action plan to include these revisions into costed implementation plans, FE 2020 action plans, and health financing and universal health coverage related reforms. And finally, the case studies from Madagascar and the Philippines have given us insights into the barriers and enablers we might see in two different contexts. Madagascar, with its nascent health financing system, showed us multiple barriers due to the absence of policy instances for the country. The Philippines, in comparison, has a much more mature health financing system and many policy instances with direct applicability for financing family planning. It was also interesting to examine the potential implications on family planning as Philippines actively undergoes health sector reforms under the 2019 UHC law. Given the expected health financing reforms in both countries, the future holds promise for decision makers to use the framework to gain a deeper and nuanced look at how to best provide sustainable financing for family planning. Thank you for joining us today. This concludes our presentation, and I will now pass it over to Bethany for question and answer.
Great, thank you so much. We have had several questions streaming in throughout the broadcast. So I will just start and we'll get through as many as we can. And then for those of you who have not yet typed your question, there's still plenty of time. So please do so while we get to this first batch. So the first question is from Katie. She's just wondering, is the checklist available in French?
Hi, Katie. Thank you for the question. The checklist is not currently available in French, but this is definitely something we can consider. The Madagascar case study will be available in French, as we want to ensure that our French speakers can access those materials. So yes, thank you for that.
Great, thanks, Elise. So I'll go to the next one. This is from Paul, and this is for Dr. Andrianaev. Are there disincentives for subnational governments in Madagascar? Sort of a situation where a regional government's allocation from national government is tied to indicators like number of population in the district. And Dr. Andrianaev, you'll want to unmute.
Yeah. So can you repeat the question, please, Erin? Katie?
Of course. So
I had a bad connection.
No problem.
Yeah, please.
No problem. So are there disincentives for subnational governments in Madagascar? Sort of a situation where a regional government's allocation from national government is tied to indicators like population size in the district, for example.
So actually, there are no incentives at all. Madagascar's health system is very centralized, and this is one of the issues of the health system in our country. And this is one of the issue why we have problems to write on this policy on health financing. It's very centralized, and it's not easy at all to coordinate all the subnational level, and the health system is quite top down, and it's not easy at all.
Great.
And this case, I will just follow on to what Noraheng was saying. We recently conducted a financial flows analysis in Madagascar, and looking at, as Noraheng mentioned, it's a very centralized system. So while the regional government does ask for or send up their budget request to the central level, that's hardly ever honored. And I don't think that there is a specific calculation that is made at the central level in terms of percentage of the budget that goes to each region based on population, but it is significantly tied to the previous year's allocation, and doesn't often get increased from there. So they do get a very small percentage. If you're interested in learning more about the financial flows, I'd encourage you to check out the publication on our website.
Yeah.
Thank you so much. I'm going to move to the next question because we've got more coming in. This is from Andrew Zapfel. Does the policy framework include dissemination of policy information to general population and key populations in culturally appropriate ways? And if so, what were findings from the pilots?
Thanks, Andrew, for that question. We did include in the framework, there is mention of adolescents and youth and other target populations in the family planning scape. So we did look at how policies, laws, and regulations can affect access to adolescents, for example. in both of the countries. There is in each of the case studies, I don't know if Dr. Hank or Dr. Piniella would like to speak more about some of the findings, but essentially there is a relatively supportive environment for at least for adolescent access in terms of family planning bodies.
Fabulous. Thanks, Elise. Next one is from Mozam Ali. The presentation noted that there is exclusion of removal of LARCs from PhilHealth benefit package. Which cadre of health workers are allowed to remove LARCs, and what is the average cost for removal? So Dr. Pinelo, you'll want to unmute.
When the benefit package for the progestin subdermal implants was introduced, the intention of the package at the time was for a one-time cost to cover the insertion as well as the removal of implants within the public sector at the time when the package was being designed. Over time, as use of progestin subdermal implants have become more popular and more private sector providers are providing the service, this problem about the lack of reimbursement for the removal of subdermal implants became apparent. And while insertion can be done in outpatient clinics like rural health units or health centers, removal is usually done at the level of ambulatory surgical clinics or hospital OPDs or emergency rooms because of the need to do some excision, especially when the implant that was administered would have some adhesions with the adjoining tissues, or what we would call a complicated removal. So this is one gap that is currently being addressed by PhilHealth. They're studying the introduction of a implant removal package, but at present, removal of the implants is free in the public sector system. And so any person who wishes to have an implant removed can just go to any public hospital, and this will be provided for free. Thank you.
Great, thank you so much. Our next question is from Gamera from Engender Health. It is important to evaluate and monitor how COVID-19 is going to affect government financing for family planning, programming, and LMIC. It is important to come up with the standard tool to do this. So that was less of a question than a comment, sorry, but thank you so much for that comment. I think that's really important. Do any of the panelists want to follow up on that? Or I can also move to the next question.
Sure. Bethany, I can just add a little bit to that. I think that's a really critical point to make, because as Dr. Carlo pointed out in his presentation, there's going to be a new norm after COVID, and we have to figure out how we're actually going to implement in that new environment, and our policies are going to have to potentially adapt and change a little bit to make sure it can work in the new type of environment we're going to be working in. So our tool wasn't specifically aimed at COVID, since we kind of worked on this prior to the epidemic, but as policies shift and change, it is something that could potentially be adapted to see how the policies are working under the new environment.
Wonderful, thanks, Erin. The next question is from Jay Gribble. It seems like there's both an opportunity to use advocacy to remove barriers, as well as accountability to hold governments to follow through on enablers. What plans do you have to engage stakeholders in Madagascar and Philippines to follow up on the opportunities and challenges identified in the country examples?
Thanks for the question, Jay. Definitely, this is the tool offers a great opportunity not only to remove the barriers, but also to make sure that the enablers stay where they are. That's why it was very interesting in the Philippines case study to look at how the new UHC law could potentially affect family planning down the line, depending on how it's implemented. And to be able to identify those enablers up front and to ensure that those remain the same and continued throughout the implementation of the new law will be critical. I think this is something that we want to further discuss with stakeholders in both countries. As mentioned in the presentation, the FP 2020 Secretariat connected us with FP 2020 focal points in each country for stakeholder consultation for each of these countries. And we will be following up with each of them as the case study documents are available in the next couple of months to see what kind of next steps we can take and ensure that the actions are then further implemented into either cost implementation plans or a concrete action plan for taking forward in country to secure those enablers and then to ensure removal of any existing ones. In Madagascar, for example, we are working on also supporting the development of a health financing policy. So we will want to ensure that family planning is part of that discussion in terms of priority services to include and finance long-term sustainability.
Great, thanks, Elise. This is probably going to be our last question, and this is for Dr. Carlo. How can this type of framework be used prospectively to inform the course of health sector reform and situate family planning when some of the ways in which the UHC law will be implemented are still unclear?
I have had no personal experience in applying the framework as this study is still ongoing. But judging from how it's currently designed, it actually takes on a health systems framework in terms of looking at the policy actors as well as the institutions that are going to be involved, and in terms of aspects of implementation such as financial protection that are of primary interest for a project such as USAID's ProtectHealth. And I think the way forward here is that the tool can be used as new information comes in, given the operating environment, changes in policies, to update the analysis on what can be identified as barriers as well as enablers. And I don't know if it's part of the coverage of the study, if the study will actually move forward from using the framework not only to identify enablers and barriers, but also to identify specific actions that can be taken by using the framework as a solutions, as a means to generate or identify solutions as well. Thank you.
Great. Thank you so much, Dr. Pernello. And I'm going to toss it back to Elise to close us out. But before I do that, I just want to thank everybody so much for joining us. This has just been a tremendous turnout, and loving all the questions and engagement here. So if you're interested in attending future family planning webinars, you're going to receive a follow-up email from us in the next 2 days containing the link to the recording, as well as the link to our website where we hold announcements of all the forthcoming webinars. And please do mark your calendars for Thursday, May 14th at 10 a.m. Eastern. What is Measured Matters, Monitoring Family Planning Costed Implementation Plans. And also for Thursday, May 21st at 1 p.m. Eastern. Diagnosing Inequities in Family Planning Programs, a case study from Uganda. We've got lots of great content coming up, and we're so glad to have you with us. Thanks again, everyone, and back over to you, Elise, to close us out.
Thanks, Bethany. So just before we close, we do want to acknowledge those who have participated in the consultative discussions with us and the development of the 2 case studies in Madagascar and the Philippines. Your contributions were really essential to the finalization of the framework itself, and we hope that the results from the application can provide useful information for securing sustainable financing for family planning in the ongoing health financing reforms in your countries. And we'd like to thank the FP 2020 Secretariat for their collaboration and help in connecting us with the focal points in country. So thank you all so much for joining us today. Hope you enjoyed the presentation, and please look out for the guide on our website to learn more. Thanks. Have a nice day.